Hello, everyone. Welcome to the Value and Innovation Forum's briefing on Medicaid redeterminations. It's my privilege to serve as your moderator for today's discussion. I'm Nisa Shafi, and I'm the Associate Director of Public Policy at the Alliance of Community Health Plans. The goal of the Value and Innovation Forum is to present diverse, unbiased perspectives on different policy issues that are controversial or time-sensitive. Ideally, we aim to translate these policy issues and understand them very well so that partners are well equipped in advancing their advocacy efforts. With Amgen's financial support, the Value and Innovation Steering Committee comes together from various patient organizations and selects group topics that they think will resonate with an audience of primarily patient advocacy groups. The Value and Innovation Forum plans to conduct 4 of these briefings per year, so we greatly welcome your ideas for future topics. I want to take a moment to recognize the members of the Value and Innovation Forum Steering Committee: John Clymer, Executive Director of the National Forum for Heart Disease and Stroke Prevention; Dr. Alan Balch, CEO of the Patient Advocate Foundation; Michael Bagel, Associate Vice President of Public Policy at the Alliance of Community Health Plans; Dr. Donnell Ivey, Director of Community Programs at the Association of Black Cardiologists; and Jeffrey Davis, Director of Regulatory and External Affairs from the American College of Emergency Physicians. And now to today's topic, Medicaid redeterminations. As many of you are listening are probably aware, March 31st marked the end of COVID-era flexibilities granted to states to prevent disenrollment of Medicaid and CHIP enrollees. Directly following that, on April 1st, marked the official start of Medicaid redeterminations, an otherwise annual process that had been halted for the past 3 years to protect consumers during the pandemic. As a result, Medicaid and CHIP programs witnessed historic levels of enrollment, covering over 90 million adults and children. Our expert panelists will discuss the implications of states resuming normal operations and what this means for consumers and stakeholders alike. But first, I would love to share about the work that ACHP and its member companies are doing to protect Medicaid consumers during this very unique time in our nation's healthcare history. ACHP member companies consist of the nation's top performing nonprofit regional health plans, serving millions of consumers in all lines of insurance, including Medicaid, in 37 states and DC. And throughout the pandemic, our members have leveraged their strong community ties to disseminate critical communications to consumers about changes in insurance and what they should expect. And this information came from trusted partners such as community ambassadors, state affiliates, and local provider networks. And at ACHP, we've been at the forefront of this issue through our congressional and administrative advocacy, securing significant wins for Medicaid consumers and the entities that serve them. 2 major accomplishments include providing states with a glide path for the enhanced federal Medicaid match that was passed in the Consolidated Appropriations Act last year. And this provides states with critical financial support to conduct eligibility for 90 million individuals. The other big win was securing the ability for health plans to text consumers, alerting them of pending renewals, a flexibility that was previously unavailable to health plans and posed as a major barrier to health equity. ACHP is incredibly delighted to be a part of this conversation, and we have a fantastic panel of experts today who will provide additional context and impart their expertise on this matter. So with that, it's my pleasure to introduce our panelists. Sally Mabin is the Senior Program Director at the Center for Health and Wellbeing at Princeton University. Ms. Mabin is responsible for the management and oversight of state health and value strategies programming and works with subject matter experts to develop and disseminate products to assist states in their efforts to transform their healthcare systems. She has worked in both state and local government in New Jersey, New York, and California. And she comes to Princeton after serving in the New Jersey Office of Management and Budget with responsibility for the Department of Health and the Department of Children and Families. Next, we have Matt Powers, who is the Managing Director at Health Management Associates, a former Illinois Medicaid administrator. Mr. Powers provides expert consultation on Medicaid policy and financing projects. He currently works on a variety of projects to help providers, foundations, and others implement policies that strike a balance between controlling costs and maintaining coverage for patients. And finally, we have Dr. William Shapiro, a health economist and an assistant professor in the Division of Health Policy and Economics of the Department of Population Health Sciences at the Joan and Sanford Weill Medical College of Cornell University. And Dr. Shapiro studies Medicaid and healthcare safety nets in the United States. Through his research, he aims to identify policy levers to address socioeconomic, racial, and ethnic disparities in health and healthcare. After we hear from our panelists, we will have a pretty robust discussion on the remaining issues that the panelists feel are important for your consideration. And I wanted to go over a few housekeeping notes before we begin. You can utilize the Q&A function on the Zoom feature to pose questions, and I will pose them to the appropriate panelists when the time comes. Audience members can upvote questions that seem especially interesting, and those questions will appear at the top so they can get noticed. And we encourage listeners to share their reactions, their thoughts about the presentations in the chat feature, but to reserve their questions for the Q&A feature solely. But so with that, let's get started. I'd love to first welcome Sally Mabin, who will provide some background on the continuous coverage requirement.
Great, thank you so much, Lisa. And thank you to the Value and Innovation Forum for bringing us together for this conversation. So on the next slide, I have a quick overview of the organization that I work for, the program I work for, which is State Health and Value Strategies. And we are funded by the Robert Wood Johnson Foundation. And our mission is to assist states in transforming their health and healthcare. And that means that we've been working very intently on unwinding for well over a year now, and have developed a multitude of resources to support states as they plan and operationalize unwinding. Okay, so moving on to the next slide. Okay, so this slide brings us back to those early days of the pandemic, which I'm sure many of us have strong memories of. And it specifically lays out the steps that the federal government and Congress took in response to the public health and potential economic impacts of COVID-19. So I want you to focus on the two boxes in orange at the top of this timeline. The first is January 31st, when the then HHS Secretary Alex Azar declared the public health emergency. And the second is March 18th, when the president signed into law the second stimulus package, which we know by its shorthand FCRA, but which stands for the Families First Coronavirus Response Act. So this gives us a sense of, I mean, those two points are important in thinking about like what laid the groundwork for the Medicaid continuous coverage requirements. And as the next slide explains, FCRA was responsible for providing states with increased federal funds in the form of a higher federal matching rate for Medicaid. However, it came with a very important requirement that states could not disenroll anyone who were eligible, or who were eligible as of March 18th, 2020, or anyone who became eligible after that date. And so, as Lisa said in her opening remarks, that date, that requirement has now ended. And I'm going to provide us with a little bit of an overview of how we got to the end date that we did of March 31st. But just to say also that to comply with this requirement, states had to make significant changes to their eligibility and enrollment systems. They basically put the process, as Nisa was saying, of renewing folks on their roles eligibility on hold. Now, some states actually did send out or continued to send out renewal notices and ask people to return paperwork, which put them in the position of having a sense of who was going to be eligible versus not once the continuous coverage requirement ended. But no state was allowed to terminate anyone from coverage unless they decided to opt out of the enhanced federal match, which no state did. So now that the continuous coverage requirement has expired, we can get to, and we'll get to why in a moment on the next slide. States are now charged with conducting renewals for all of their Medicaid enrollees, irrespective of whether or not they were doing renewals over the course of the period since the start of the public health emergency. So on the next slide, as you can see, up until December 2022, states were basically in limbo, waiting for when the president would declare the public health emergency to be over. And as Nisa said, in the advocacy efforts of a variety of stakeholders and through the, let's say, strong voices expressed by states, Congress passed legislation which codified which set a new end date for the end of the continuous coverage requirement, which was March 31st, 2023. So it decoupled, as we like to say, the Medicaid continuous coverage requirement from the public health emergency and ended this limbo that states had been experiencing. So that was a huge, one of the biggest pieces of the CAA, as we call it. But another important piece is what you see in this light purple box, which is that it also now includes, and we've now started this, a phase down of the federal matching rate. And so as it's phased down over a sequence of steps over the course of the next 12 months. In addition, as the blue box states, the CAA implemented or requires now new Medicaid chip and marketplace reporting requirements. So that will allow greater oversight on the part of CMS of the unwinding process. And it also provided CMS with targeted enforcement powers to be able to hold states accountable for ensuring they are in compliance with both the reporting requirements and also the federal parameters for unwinding. So on the next slide, and this is my last slide, you can see here, I just wanted to end on, what has the continuous coverage requirement achieved? Well, it's achieved a huge increase in coverage, right? We went from, and this slide only goes through October 2022, but from February 2020 through October 2022, enrollment in Medicaid and CHIP grew by 20 million individuals, which is an increase of 29%. And Matt's gonna pick up in his presentation on, well, what do the estimates look like now that the continuous coverage has ended of who is going to lose coverage. But I just wanna pause and flag that since people of color are overrepresented in state Medicaid and CHIP programs, it's important to flag that, in fact, we could see a disproportionate impact on that population. Okay, so I think that's the end of my slides, and I'm going to hand it over.
Thank you. Great presentation, Sally. I really appreciate it. Appreciate everybody who's on and who's a part of this, because I really think it's a very important issue that deserves a lot of attention. So really appreciate everybody's energy on this. First slide, I'm going to hit a couple high points. The very beginning, Sally's timeline brought back a lot of memories. The very beginning of the pandemic, which we weren't sure the extent to which this is the depth and extent to which this is going to have an effect on all of us. What we pivoted to pretty early is deciding, because I work on state-based issues, state-based health issues, so primarily Medicaid, some marketplace, uninsured, et cetera. So what we pivoted to immediately was we felt like this was going to be unprecedented time. So what we did was pivot to a state-based model. So we modeled out the potential effects, as you saw Sally's slide, going from 70 to 90 million. It's probably about 93 million or so today, possibly 94 million folks that are enrolled in Medicaid, historic high. There were a lot of people trying to understand and project what that would look like, because it really was one of the first tests of the new safety net that was created by the Affordable Care Act. Affordable Care Act kind of created that new categorical eligibles of childless adults. So for about 40 states now, it was a new test. So what we did was model that, because as unemployment peaked at about just below 15%, we thought this is really going to have a profound effect on Medicaid coverage, and it's going to be very heterogeneous, particularly heterogeneous because of the way states implement policies just a little bit differently. Just point out a couple points and try to be complimentary of Sally's remarks, because hers were terrific, and I want to compliment those. We're down the nice red bar. We're down. We project during the unwind that we're going to go down about 14 million Medicaid enrollees. Some of these will, and on the right side, the arrow up, many of these will go to uninsured status, an increase in marketplace status, and about a fairly steady on the employer-sponsored insurance, which is ESI. What we're seeing now really is a historic high on Medicaid participation rate. If you remember before the pandemic, and we'd look at the uninsured rolls, the folks that didn't have coverage, uninsured people, that would typically be around 30, 35 million people. Frequently, a good portion of those people are difficult to reach, and their participation rate's low in Medicaid. So they're eligible for Medicaid, but they just need to get the word out to them. And Nisa said a brilliant thing. We need to up our game as policymakers and people who are interested in policy to be able to get to individual patients, move on from the US Postal Service to text messages. So it takes a while for the system to try to respond to how, consumer behavior and people behavior work. But I love that Nisa pointed that out. I thought it was a really important and a low-key policy measure. It's really important. To a couple other little things, as this, and Sally pointed this out, I believe, was continuous coverage is a new law that was passed, and that'll take into effect at the beginning of next calendar year. So while we have probably the most historic eligibility changes and redetermination changes that's ever gone on, not even probably, they are the most important. It's gone on since 1965 when the program began. You're going to also have an important policy measure, which is children are going to have 12-month continuous eligibility. But before that starts, we still have to redetermination all 90 plus million Medicaid enrollees. So it's a huge deal. Last point on this slide I wanted to make is just also we're facing some economic turmoil in a different way in 2023 or currently. So there is a potential that we didn't factor into our 50 state model. So we've modeled out every state. We did not factor in a recession, but that does, in an aggregated manner, potentially increase Medicaid enrollees by anywhere between 300 to 1 million individuals. That's important because what we just have to do is stay tuned with our economy and look at what unemployment rates look like, look at what inflation looks like. So that's something we've looked at a higher level, but we're gonna, depending on how that goes, we're gonna move on to modeling that at a state level. So here, this is just, I don't want to spend a lot of time on this, but this just tries to flag the different ways that states are approaching, the unwind. They have a fair amount of latitude from the federal government in the way they choose to conduct themselves policy-wise during the unwind. So you have a choice as a state, as you can see, 5 states upper right-hand corner in April. You have a choice to start disenrollments in April, but you also have that choice to start them later in July. So it's a state choice. I have heard already, there's one state that I won't identify by name that this is real. It's not a drill, as we used to say back at the state. This is not a drill. There have already been tens of thousands that have lost in a certain state, and that's just between 1% and 2% of their total enrollments. So that is not, it comports actually with the way most people are looking at their unwinding projections. But this is the first real evidence I had. About 30-some thousand people are off, and they still have that opportunity. You still have retroactive enrollment. You still can reach back out and engage. That's an important point for patients, providers, et cetera, to stay engaged. Just because it appears they're not insured right now, if they're eligible, how to re-engage back into that process. So let's go to the next slide, please. Just wanted to point out, shout out to Nisa's point. I loved her text point. That's that currently we still have a general reliance on snail mail. So that's why it is important as advocates, as people who are interested in these policies, to really get updated addresses, to work with your risk-based managed care. 75 million out of about 95 million Medicaid enrollees are enrolled in risk-based managed care. That could be Molina, it could be Blue Cross Blue Shield, it could be CareSource, it could be Cook County. I'm in Chicago, it could be Cook County Care. So getting that update with your managed care company, your state, your caseworker, your provider, getting updated addresses is critical. And the last thing that I don't think a lot of people talk about on the state side, I still have a soft spot for state and state employees. This is a workforce that's been under a tremendous amount of challenges for the last several years. Remote was very much an in-person workforce, became a remote workforce, very high turnover in this workforce. So W-2 bearing state employees do the redeterminations. They conduct the redeterminations, the adjudications. Big turnover in here. We had a stat that South Carolina identified. Robbie Kerr is a great Medicaid director in South Carolina. At a 25% turnover back in the years 2021. Next slide, please. These last three slides are just some visuals to talk about how the potential folks that will be potentially uninsured. And this is how the 14 million essentially distributes by state. The darkers, and I know this just correlates to population, frankly. So it correlates to the larger states or the darker colors. But I think rather than put it in a percentage, I think it's important just to look at these are real people who potentially will lose Medicaid coverage. And so we do that by state. Next slide, please. This is for history buffs, just really kind of shows. And one of the things I like to point out about this is historically, when you see a recession, there frequently is a notable policy event. So if you see a notable economic event, you'll see you'll see some of our kind of most important law changes that happened after that. And I'm going to focus more on the federal law changes. State law changes happen every day, and they're, I'd argue, as important. I have a bias there. But you can see the ACA, I think it's easy to forget, the Affordable Care Act was passed just after the big recession in 2008 and 2009. And as Sally pointed out, other policies have already come about and will probably come about given what we've gone through. Telehealth, we are in so much of a different place with telehealth, which has so many implications with respect to access to specialty care, eligibility, all kinds of issues. So we're in such a better place with the ingredients are in such a better place as a result of what we've just gone through. And it would not surprise me that it's going to help elevate our conversations with respect to what we can do to continue to improve our healthcare system. And lastly, this is a similar graphic to what was 2 slides ago, but it just kind of shows where Medicaid, and I think I'd focus on that little 15-ish%. The United States as a whole is in the middle of the screen there. Obviously, South Dakota is going to perk up because they are an expansion state. North Carolina, as I have in the title, but not in we haven't got it into our 50-state model. North Carolina will actually increase as well because of their choice for expansion, but this just breaks it out by state. And it just for certain, people who like to look at this, expansion and non-expansion is not a huge factor. It's kind of heterogeneous there, even that you might think it might spread out differently or distribute differently. Appreciate the time.
Well, hi, everyone. Thanks so much for being with us here today. And thanks, Sally and Matt, for setting the stage on this topic. So I think a lot about how Medicaid structurally contributes to disparities in healthcare access and outcomes, but also how we leverage as a powerful policy tool for improving health equity. And I think there's significant reason to believe that the unwinding of the pandemic's continuous coverage provisions will have a disproportionate negative impact on coverage for racial and ethnic minority populations in the US without really concerted effort by federal and state governments and their community partners. As Sally previewed, I think one reason is simply that Medicaid is a disproportionate source of coverage for minority populations in the US. But another reason I think is on this slide. So back in August of 2022, the Department of Health and Human Services estimated that about 83% of those enrolled in Medicaid, once the continuous coverage provisions ended, would maintain their enrollment. Another 10% or so, shown here in yellow, would be deemed ineligible due to income changes and would be disenrolled from the program. But then there's a remaining 10% who would be disenrolled despite being eligible. So this is so-called administrative churn, where administrative barriers to accessing a public program like Medicaid limit access to the public benefit among folks who are otherwise eligible. So on the next slide, you can see that HHS projects that this administrative churn will be higher among children. So you can see among children who are projected to lose coverage, 74% of those losses are projected to be due to administrative churn, relative to only 27% of coverage losses among the near elderly, those 55 to 64. And this is in part a function of the fact that most states have separate CHIP programs, and in those CHIP programs, many choose to charge premiums, and those premiums are themselves an additional hurdle to renewals. On the next slide, you can see that administrative churn is also projected to have a disproportionate impact on members of minoritized racial and ethnic groups. So each bar here again reflects the total number of people expected to lose Medicaid during the unwinding process. And in yellow, we have what proportion of those losses are attributable specifically to administrative churn, where these are people who are eligible for Medicaid but will lose coverage. So we can see that administrative churn is projected to explain about 40% of disenrollment among white enrollees, but it's a disproportionate source of enrollment losses for other groups, 52% among Latino enrollees, 48% among Black non-Latino enrollees. On the next slide, you can see, I think a really important point, which is that states, I think, even before the pandemic, really varied in the extent to which they have taken steps to mitigate administrative or procedural sources of coverage denial. So this figure reflects the proportion of eligibility determinations that were denied in a given state. So each bar here is a different state. This is looking at a sample of 22 states. So each bar reflects the proportion of determinations, so new applications and renewals that were denied for purely procedural reasons. So not because someone was deemed ineligible because their income was too high or they didn't meet other eligibility criteria, but because some element of the application process couldn't be finalized. And so someone couldn't be reached to verify information, perhaps an address changed and there was mail they couldn't follow up on. And so we see here that on the left, there's a state where 25% of determinations are denied for procedural reasons. So this is a huge, huge amount. But then we see on the right-hand side, there are states that really have taken, I think, meaningful steps to mitigate this phenomenon. On the next slide, you can see, I think, the right side here. So this is some data from a survey conducted this year by the Kaiser Family Foundation, where they found, almost all states are taking, meaningful steps, I think, to reduce this phenomenon of administrative churn, and including, reaching out to update enrollee mailing addresses, leveraging data, from the national change address database, among other sources, trying to extend the renewal process over as much time as possible, as both Nisa and Matt highlighted, trying to follow up with enrollees, not just via mail, but also via phone, email, or text messaging, taking multiple steps to follow up with folks if, initial outreach is not successful. And then I think, as Matt really highlighted, taking, meaningful steps to improve and boost staff capacity in state Medicaid programs. So on the next slide, I think you can see the other sort of side of this coin, which is that states do really vary in the extent to which they've invested in important processes to reduce churn. So, one key strategy to reduce churn involves so-called ex parte renewals. It's where states engage in redeterminations based on information the state already has from other sources, whether it be, for example, from an enrollment information they obtain through the Supplemental Nutrition Assistance Program, or tax data or other government programs. So over half of states, 28 states, complete less than half of their renewals using this ex parte process, leveraging other data that are available, which, I think, again, highlights the extent to which states are going to have to engage in direct outreach to enrollees, and that really can have a disproportionate impact on various communities. So I think the federal government is very focused on ensuring states take meaningful steps to reduce churn, and it's effectively authorized to reduce Medicaid funding if states do not. This is an area that I think will definitely require ongoing federal oversight and enforcement, and one where states are and they need to continue to make meaningful investments to ensure that this process does not have disparate impact and an avoidable impact on coverage among those who are truly eligible for Medicaid. So let me stop there, and looking forward to the discussion with the group.
Thank you so much, Dr. Shapiro, and Sally and Matt. Those were really incredible insights. And I wanted to head into the Q&A portion of today's program, but wanted to remind the audience to use the chat function to share their thoughts, and then also the Q&A function for specific questions that I could direct to the panels themselves. But for the first question, I'd love to ask the entire panel, what options do you feel are available to patients, and how are they being informed about the process? So Matt touched on the fact that there's going to be transitions in coverage, and I would love to hear from all of you a little bit about what you think, how we can inform patients and make sure that they have continuity of coverage throughout this process. So I open the floor to whoever wants to take it on first.
I'd be glad to take a shot. Can you? I'd start with your provider. It could be, or a clinic, FQHC. Your provider. I'm going to take from the point of view, Nisa, of a Medicaid enrollee, but your safety net providers are going to be critical to this. I'd also, as I talked a little bit about earlier, I do think that we don't spend enough time talking about the fact that Medicaid programs, primarily in the year 2023, are a big part of how an enrollee works with the system is through managed care organizations. So I don't think that gets enough kind of discussion points. Is the MCOs have a financial incentive to keep that, to have less disruption for that enrollee and for their member. So I'm crossing my fingers that this is 2023 is a lot different than what we've seen. That and managed care penetration rate is very, very high. So I'm hoping that those kind of economic forces come together, and it's not just the enrollee's responsibility. It's not just the state's responsibility. It's not just the provider's responsibility, but because that penetration is so high, I'm kind of crossing my fingers that the MCOs who are going to be able to play a bigger role in retaining people that are eligible for the program, rightfully eligible for the program.
Matt, I had a follow-up question to your point about managed Medicaid enrollees. Many enrollees in managed Medicaid plans aren't aware that they're in Medicaid to begin with. And when they receive communications from their state during this process, it could get confusing. So I open it up to you, Matt, and Sally, and Will as well. But how do you feel is the best way to communicate to those enrollees to ensure uniformity in messaging and not to confuse them throughout this process?
I'm
Sally,
happy
you
to
want to take a stab at that?
I was going to say, I'm happy to jump in, Nisa. So we've already talked about text messaging, and as you highlighted, Nisa, the very important decision, loosening of the rules around text messaging. I'll just leave it there. But I also think that what we've been seeing among states is really leveraging other stakeholders, but stakeholders that are really familiar to Medicaid enrollees and know them where they live and where they are. So that could be beyond providers, community-based organizations. And that describes a lot of different organizations. But we've seen a couple of states actually providing like mini grants to CBOs to help with outreach so that they can fund outreach activities because they clearly understand the importance of those touch points in reaching Medicaid enrollees. So and then in California, they have this ambassador program where they've created specific communications materials just for their ambassadors to do outreach. So, I think the role of local, small, community-based organizations is key to sort of helping make that connection for Medicaid enrollees.
I'll just jump in to add, there is some data from some work prior to the pandemic that's looked at sort of what is the rate of folks transition from Medicaid into marketplace plans, which, for many of the folks who will be disenrolled is one of the important key options, and it's very low. So those estimates are often around 3 to 5%, which I think if we take that as a given does not bode well for the ability of states to sort of get folks who are deemed ineligible into new forms of coverage that are hopefully affordable to them. At the same time, we do have evidence that when states take really concerted steps to engage in outreach, that can do a lot to boost those transition rates. So I do know of one randomized controlled trial in California where folks were given a reminder email and then a call that actually connected them to enrollment assistance. And that increased enrollment in marketplace plans by 50%. So it had a huge positive effect. But the key is that states, need to invest in this. This requires resources. It requires a lot of, really complicated technical assistance. So I think there is an optimistic take, which is that, when we invest in these sorts of evidence-based strategies, states really can help folks transition to new forms of subsidized coverage like marketplace plans, but it requires a lot of really focused effort.
And Nisa, I just wanted to shout out to the person who asked the question because it's a brilliant question. It's a foundational issue from decades in the Medicaid program that it's kind of inherently confusing. So if you look at census data and ACS data, and the rate of uninsured, a lot of people respond to that question, what's your health insurance status? Well, I don't have insurance, but they're actually on Medicaid. So it's been a historical problem in our foundational data when we're trying to construct different, and the MCO is even a different wrinkle. It's like, well, wait a second, I'm on Blue Cross Blue Shield in Illinois. Blue Cross Blue Shield is a very big managed care plan. So they're not, it has some foundational confusion in itself. So just want to throw that out there.
Of course, thank you. The one thing we're struggling with is making sure that consumers know that redeterminations are happening and that people know that they're in Medicaid to begin with. So there's a lot of communication elements there. One thing I wanted to touch on, both Will and Sally touched on this, are the health equity implications. So it was mentioned that, you know, disproportionately, the program is represented by marginalized individuals, both from racial and ethnic standpoints, and just wanted to see, you know, how we can improve messaging on that front as well.
Sorry, Sally, go ahead.
No. Oh, I was going to say, you know, one thing that we've focused on at State Health and Value Strategies is thinking about messaging to particular populations in terms of like eligibility, categorical eligibility groups. So if we think about like the postpartum and pregnancy group, right, and making sure that messages are tailored to that population, and also to families with children. So that's one way, at least, that we've been thinking about how states can message and communicate specifically to certain populations.
Yeah, I mean, I guess just, you know, taking more of a macro perspective to start, you know, I think there are, you know, 3 reasons we might be concerned about the health equity implications of this process. And, you know, I think Sally and I both touched on them, but I'll summarize them here. One is just the fact that Medicaid disproportionately enrolls racial and ethnic minority populations in the US. And so disenrollment will disproportionately impact those populations. 2, you know, I think involves a second point involves sort of state level heterogeneity. So I think there's some evidence that states that invest fewer resources in mitigating things like administrative churn are also those that have larger racial and ethnic minority populations. And I think the third gets at the sort of disparate impact of administrative burdens. There's a variety of research that makes clear that administrative barriers to government services, you know, have a disparate impact on members of minoritized groups. And this is in part why administrative churn in this context is expected to be higher for Hispanic and Black Americans, for example. And this is things like reliance on paper forms, you know, wait times, periodic data checks. You know, I know there's evidence, again, prior to the pandemic in Texas, you know, the number of children in Texas who experienced a gap in Medicaid coverage more than doubled after the state implemented a periodic wage check policy instead of doing sort of annual renewals. And so these, you know, additional administrative checks, you know, really can have meaningful effects on enrollment and disparate impact. And so I think this is where federal oversight is very important, and the federal government's made clear states have to be transmitting to CMS information on their rates of procedural denials and call center wait times and things like that. I think CMS is going to be actively monitoring those reports and has been authorized to require states to pursue corrective action plans if it's clear folks are being inappropriately disenrolled at very high rates. And so I think there's a really important role for federal oversight to protect against the potential for disparate impact here. And then I think going back sort of down to the micro level, you know, to I think the question you initially raised, Nisa, and what Sally was speaking to, you know, there's a lot that states, MCOs, and health systems, I think, can do to target messaging and to rely on messengers who are trusted by the communities that we think will be disproportionately impacted. And so that goes again, I think, to Sally's point about, you know, really relying on community-based organizations, you know, whether it be faith-based groups or otherwise that have deep ties with the community and know how to, you know, reach those who may be difficult to reach by the state.
Thank you so much. I wanted to touch on another question, which are the implications of continuity of care, but it also ties into a question from the audience, which states, has anyone projected the potential downturn in health outcomes and the financial burden on health systems providing uncompensated care as a result of these changes? So I think the 2 questions align perfectly, and I welcome any of our panelists to take that on.
I could try. It's very doable. The data will be there. The primary uncompensated, the way that it's recorded is just in the Medicare cost reports. So I can only speak to Illinois on the numbers, but 260 hospitals in Illinois turn in their Medicare cost reports every year. There's an uncompensated section. That's the, mathematically speaking, where that uncompensated primarily shows up, on the math side, not on the human side. Human side's a big deal, different. But we can, it's easy to record that and to project that. It's probably going to be easy to model based on past experiences. I can only say this, I haven't seen any, the new version of that, Nisa, but it's very doable. All the ingredients to project that out are there.
Yeah, I'll just add, as someone who thinks a lot about sort of the financing of safety net hospitals, I'm not aware of any existing modeling that has been done. I think it's an important question. I think you could imagine the story going both ways. On the one hand, the rise in Medicaid rolls may produce uncompensated care, but I also am not certain that enough time has passed that hospitals have drastically changed their cost structures in a way that they've become more reliant on that. Hospitals are facing, I think, some financial pressures right now due to supply chain constraints and labor market shortages. But that's really affected all hospitals in many ways. I don't know of any good work that's directly looked at that question yet. I do think it's often hard to study, in part because a lot of the data that Matt mentioned, there's a lot of sort of fiscal shenanigans that goes on and sort of how hospitals report their uncompensated care, and it'd be very difficult to actually understand, what's truly uncompensated versus not. As to, how we might think this affects health outcomes, I think there is better data. So, there have been other sort of shocks to enrollment in different states over time. Most notably, there's a large disenrollment in Tennessee among kids a number of years ago, and there's been work showing that's had really meaningful effects on health outcomes. I'd point to some work by an economist at UVA, Sebastian Trelatillo, who's done some work on that topic. So certainly, I think there's been really important work establishing the causal effect of disenrollment on health outcomes. I think we know less to what extent hospitals have become reliant on higher rates of Medicaid participation during the pandemic. It's a good question.
Sally, did you have anything to contribute to that?
I think Matt and Will did a great job covering that.
Great, thank you. And I have something for another question from the audience that somewhat relates to the continuity of care concept, and that is, do we know if the Great Resignation, in particular in those people younger than Medicare eligibility, will have an impact on Medicaid enrollment in the future?
So I will say that there has been work trying to understand why we've seen the increase in Medicaid enrollment during the pandemic, recognizing there are actually two competing hypotheses, one being the continuous coverage provisions that we've been talking about, the other being the fact that we're in a quasi-recession and the Great Resignation. And so to what extent are we seeing more folks on Medicaid because redeterminations have been paused, or are we seeing more folks on Medicaid because of job loss and incomes going down? Best work I know on this topic is by Laura Dogg and colleagues. And they looked at data just in one state, I believe Wisconsin, but found that almost all of the increase in enrollment is explained by the continuous coverage provision. So that's, I don't remember the exact percentage, but over 80%, maybe 90% of the increase is explained by that. Very little of the increase we've seen over the last 3 years is explained by job loss, whether it be to businesses shuttering during the pandemic or due to folks resigning. And so I do think that is less powerful phenomenon here, but I think we only have limited data on that so far.
And my first kind of thought, Will, too, is I'm just not sure about this, so I'll declare ignorance. But workforce participation rate is, I think, kind of hanging in there. And I think that's the first thought that I have to begin to answer that question is deconstruct it, right? Let's see what longitudinally workforce participation rate, because I'm not sure, frankly, if and it's a great phrase, the great resignation, but I'm just not sure if it translates into that workforce participation rate. I think it's been pretty steady. Even look at a little factoid I had in my slides was the ESI rate. The ESI rate did dip, and then it's back up again. That ESI rate is back up again. So it's a great question. I just wish I had more ingredients to give you a nice, thoughtful answer. It absolutely could be done, though.
Thank you. Will, I did want to touch on a great point you made that hospital systems have become reliant on Medicaid payments. And we wanted to know, how can we make sure providers are looped into the conversation and hospital systems in general know that this is coming?
So I should start by saying, I don't know to what extent I don't think we know that hospitals have become reliant on increased Medicaid enrollment during the pandemic. I think we've seen some changes in hospital cost structures. I'm not certain that's attributable to this phenomenon. So I think that's an open empirical question. But I do think there are a variety of reasons that health systems and provider organizations, do have skin in this game, both financially, but also I think from a sort of perspective of moral imperative, where I think to the extent that health systems want to ensure their patients maintain access to care, that they should be actively working with the MCOs they're contracted with and with state partners and other community-based organizations as part of this ecosystem, engaging in messaging with patients. Health systems are sort of the front door to how folks access healthcare in the US and interact with a lot of these benefits. And so they're often the most common point of contact for many folks. And so I think it's very important that they play a role in this outreach process. I do think that, one concern that policy observers have is that, as folks transition out of Medicaid through the unwinding, you ideally would want them to gain new coverage where they could maintain access to their current providers, particularly for folks who are actively engaged in care. And the best evidence we have is that there's minimal overlap between Medicaid managed care networks and networks offered through plans on state marketplaces. And so that can often make maintaining access to the same provider difficult. But in many states, New Mexico, for example, requires all plans that operate in Medicaid to also have marketplace plans, or vice versa. I may get that wrong, but that is an important state policy that can improve continuity and coverage for folks who transition in and out of Medicaid, even beyond these pandemic-related policies. So certainly, I think that's actually a really important area for advocacy, where that's a really meaningful step that only a few states have taken, but I think could have a really significant impact on continuity coverage as folks transition in and out of Medicaid during this process and beyond.
Thank you. I did want to follow up your answer. What will the impact of fewer Medicaid beneficiaries be on hospitals serving rural populations? We see closures happening in rural areas all the time, so wanted to see if you or others had thoughts on that.
I'll just again sort of underscore. I don't think we know yet. I think it really depends to what extent rural hospitals have changed their cost structure to be reliant on a lower number of other groups of patients and some more Medicaid beneficiaries. I think one important question is to what extent the increase in Medicaid enrollment has come from sort of reduction in uninsured versus so-called crowd out of the private insurance market. And so some of this does reflect folks actually transitioning from private insurance to Medicaid. And so, in the short run, in many cases, actually is a payment decrease for hospitals. So again, I think the overall effects of the unwinding for hospital finances are a bit ambiguous. There are reasons to expect that it might be positive or negative in certain circumstances.
Yeah, I can chime in. I completely agree. I don't think we know yet. Now, my second point would be there will be obviously some short-term disruption, which is really concerning. That's why we're all here. There's going to be short-term disruption, but we also have to kind of take that next step back and think, what are our different rails? Of course, what we talked about, outreach, being in touch with your state agency and your community providers, being in touch with your MCOs. But that other guardrail that would not a lot of people talk about is retroactive eligibility. It's one of those, stay calm. There's other parts of law that still are really, really important to hear. So if you miss that if you miss that snail mail, if you miss that contact, you're still going to have an opportunity when you get sick. And we don't want that to happen, right? If you're eligible for the program, nobody wants them to drop off Medicaid enrollment. But that guardrail, which is going to be helpful, undoubtedly, is you still have up to 90 days. If you present let's say you're not enrolled in Medicaid, and 6 months later, I have a trauma and my leg is broken, I go to that hospital. That hospital should be very well equipped, because this is how the systems work for decades, not worked in some cases, but how it should work for decades, that you walk that patient through so that hospital, it has an incentive to get that person paid, but you have 90-day retroactive eligibility. So when you write that application out to become a Medicaid enrollee again, it'll cover all those services for the previous 90 days. So it's something not a lot of people talk about, because we really should focus our energy in preventing that from being our fallback plan. We wanted, not have the disruption on the front end. So.
Thank you. And I can't believe it, but we're almost out of time. I did have one last question, just purely out of curiosity. One thing that we're looking at is the absorption of transitions to coverage to employer-sponsored insurance, and wanted to know how we can, from a strategic communication standpoint and operational standpoint, loop in employers into this conversation to make sure that they're able to take this on as well.
Well, actually, Lisa, we've developed some specific messages that are geared towards employers that they use to inform their understanding of what's happening and the transition and changes. But I think key to this is also that consumers know that if they are eligible for ESI, that they have that window to enroll. And I think that is, there's an outstanding question there of who's really pushing that information to consumers. I mean, I think you are hearing that across states, and in the messaging that we've developed for states to use, we do talk about that, but I think it's a little bit not as prominently featured as encouraging people to move to the marketplace.
I'll make a little add also that a lot of times some of these things, we think of them as truncated, like they're all freestanding cells. But the one point on the employer-sponsored insurance, there's about 10 million people that have employer-sponsored insurance and Medicaid at the same time right now, about 10 million people. So it doesn't get a lot, for good reason, it doesn't get a lot of headlines, right? But it doesn't get a lot of play because there's subrogation units in all state Medicaid programs who are haggling it out and say, wait a second, you're paying for that, whatever, Blue Cross Blue Shield, I'm paying for that Medicaid. So it's more of on a cost sharing back end side of it. But there absolutely is a connection, and actually a historically high connection right now, because we've frozen disenrollments for 3 years. We have a really high combo group, a double. It's a different dual, right, guys? It's a dual ESI and Medicaid. So that's it's more of a financial issue, but I like Sally's answer better. It's one of those, as the disruption potentially occurs, making sure people, patients, providers are engaged. Wait a second, I'm eligible. This ESI is my prime coverage. Let's make sure this is stable.
Great, thank you so much. With that, I'd like to give my utmost thanks to Matt, Will, and Sally for your great remarks today and really helpful insights. The Value and Innovation Forum thanks you for sharing your time and expertise with us all. And hopefully all of our efforts continue beyond this conversation. I wanted to thank our audience in participating in this briefing today and joining the conversation on this important topic. It's important to note that the slides from this presentation will be made available on the Value and Innovation website, along with other resources and articles mentioned today by our panelists. The webinar recording will also be made available, so please continue to look out for upcoming briefings and feel free to suggest topics on matters of your interest for our diverse audience. And taking what you've learned today, we hope that you put all of these great insights to use in your advocacy efforts to effectively navigate the process of Medicaid redeterminations. And on behalf of the Value and Innovation Forum, thank you again to Amgen, whose sponsorship makes all of this work possible. So wanted to thank everyone again and wish you a great day ahead.